الخير جميعا. انا قلت لكم في الانترودكتوري لكتشرز على الستيت لامب اكزامينيشن تكنيكس. الحقيقه the state lamp is our يعني hand and feet
إيهاب
in
بس
the clinic. يعني this is our
إيهاب
stethoscope. نعم
إيهاب
نعم
انت دلوقتي ظهر ايوه كده، ابتدت تظهر اول سلايد سليت لامب اكزامينيشن. اوكي
اوكي.
جو اهيد.
انا الستيت لامب باي مايكروسكوبي. دي الحقيقه the slit lamp السليت لامب باي مايكروسكوبي is our hands and feet. الحقيقه ده الستيتوسكوب بتاع الانترنست، وده الالترا ساوند بتاع الاو بي جي ان. السليت لامب is a low power compound microscope combined with high intensity adjustable illumination system. والحقيقه الميزه the advantage of the high intensity illumination system ان it can be focused as a slit beam. It has two components: an observational system and an illumination system. The observation system they allow some reflection of the incident light at each surface that it encounters. With the anti-reflecting coating, it increases brightness by 20%. والميزة في الميكروسكوب الباينوكولار compound microscope that it has a working distance of about 10 centimeter between the objective and the eye of the patient, وده allow us to maneuver within the distance. Where it has been a compound microscope, a stereoscopic, meaning three-dimensional viewing system. As the light emerge and focus on both eyepieces, and also it has a range of magnification 8 times, 16, 25, 10, and 40 times magnification, depending on what you want to do and what's the objective to be seen. General features of the slit lamp for everybody of us that would know. لو هو mounted على unit فاحنا we have to put the unit on and to see where the electric power of the slit lamp is, and to put it on as well. It's very important to adjust the eyepieces to our interests. That is by approximating or distancing the binocular, and as well if you wear glasses, so you can pinch in your glasses into the slit lamp لو انت +1 او -1 or so. او you can use وده الفكره في الالاستيك او elastic band around it. You can use your glasses because this elastic band will prevent scratching of your glasses if you like to use your glasses with the slit lamp. It's very important to unlock and move the slit lamp. This is the lock and lock button, and it allows gross movement, and it can be the target of regard. It's very important برضو ان احنا adjust the patient. Very important. عندنا chin rest هنا and the head rest. The patient has to be his chin to be put onto the chin rest and the head onto the head rest, and the lateral canthus should be within the knob اللي هي موجودة on the head rest of the slit lamp. في also هنا an examination target that can be used for the left and right eye to give a target to the patient as well. And we also have to be seated on a comfortable chair. Remember that we spend many hours in the clinic examining the patient, so we have also to be comfortable sitting on the chair. This is the binocular, and this is the how to operate the slit lamp. الحقيقة برضو it's very important to know a little bit about the high intensity light source that can be focused as a slit beam. Light has 200 milliwatt per square centimeter. Most of the bulbs are halogen, and now we have the LED light. الحقيقة we have so many filters. An unfiltered wide beam filter. Unfiltered that is an intense illumination source. When we put the knob on the slit lamp illuminator, to the extreme left. This is the high unfiltered white beam, and this is an intense beam. Then comes the neural density filter, well, this is a weaker neutral density filter. This is a weaker intensity of illumination as the filters come up to absorb some of the energy and the light, وmaking it higher, less the temperature, less of a heat. Red free is the next filter, and this is very useful to see through hemorrhages and also to look at the nerve fiber layer. If you want to evaluate the optic nerve and the nerve fiber layer, use the red free or the green filter. And at the very end piece of the knob is the blue filter that we use to with the fluorescein to examine the integrity of the anterior corneal epithelium, and also to see the intraocular pressure by a clinician thermometer. ايه هي methods of the anterior segment elimination؟ هي عندنا several methods of anterior segment elimination اللي هي direct elimination, retro elimination, the sclerotic scatter, and the specular reflection. We will go through, then this is a very important issue to be understood. And the more we understand about what we do with the slit lamp, the more you can get data and you can see the cells. And you have to remember that we are not different than pathologists. We sit at the slit lamp at our compound microscope with up to 40x magnification, and we see the cells. We are no better than, our pathologists are no better than us. We are an ophthalmic pathologist sitting at the slit lamp looking at every patient to see details. The beam, we have to know some characteristic about it. We have from the top knob هنا في ruler from 1 to 8 or from 1 to 12 depending on the types of slit lamps. وفي برضه special characters, يعني في special types of slit lamps. We have an S, we have a round with a star within, or we have هنا a square on the keeler, and the knob can go from 1 to 8 or 12 millimeters. This is how we increase through the knob هنا the length of the beam. احنا عندنا split beam, we increase the length from 1 to 12, and we can decrease it to the special character, and we can also turn it into an angle or an oblique line or a horizontal line. وده allow us to measure accurately pupillary diameter, for instance, or tumor dimension if they are present on the surface of the eye or even in the fundus of the eye with the biomicroscopy. Remember that the length is a useful tool to measure surfaces. The knob on the bottom end of the slit lamp has a width function. It makes the slit beam or the beam more rounded and more difficult on what you want to see. When we examine a patient, when we put a patient comfortably on the slit lamp, we have also to remember that we have to be very systematic. What I do is I always examine the right eye. Even if an examiner asks you to examine the left eye, ask him politely, may I see the right eye first? Because sometimes there are clues that are in the right eye that would definitely help you in the left eye. لو جاله left eye has مثلا for instance vitreous hemorrhage, and you want to test your biomicroscopic skills and you can see nothing. If you examine the right eye and the patient has a proliferative diabetic retinopathy, to give you a clue, and the examples are endless. This is one reason I always start by the right eye. And the second reason is to be consistent, and consistency هنا is important, is very important. Why? Because if you are at the clinic and seeing 100 patients a day, you have so many interruptions while you're doing so. And if you are interrupted in the middle of examining the patient and you don't know which eye was examined systematically, you know in your mind that you examined one eye, if you go back to see the patient, you will be lost. Did I examine the left eye or the right eye? Finally, to my mind, always be systematic in your life. Always do the same thing the same way and repeatedly to not miss signs that can be important. To be also systematic, we have to go through the examination of the whole eye as it opens up in front of us: eyelid, lash line, lacrimal system, conjunctiva, cornea, anterior chamber, iris, lens, and anterior vitreous. And this is the different types of illumination we use with each structure, and we will go through this. So we use the wide diffuse beam as a pen light under microscopy, under biomicroscopy, to examine the lash line, the roots of the lacrimal system, the palpebral conjunctiva, and the upper lashes as well. So this is how wide we use the widest and the tallest beam of moderate brightness, not to irritate the patient, and the 10x magnification is usually enough to examine and find such findings. And you can see, we can see details. We can notice, for instance, the papilloma, the eyelid. We can measure dimension of. We can see a basal cell carcinoma on the lower lid eroding the lash line and inducing madarosis. Squamous blepharitis, everything can be noted with the diffuse illumination. We also use the direct illumination. We use the slit lamp as tall enough and of 1 to 2 millimeter wide and moderate brightness to see high contrast structure like the iris, anterior chamber, and the vitreous. And we angulate the object, the slit lamp, up to 40 degrees. Also to get مهم جدا to get optical section into the cornea, that's transparent structure, and the transparent structure, and through the lens as well. So we can have also using the optical section, which is a very unique criteria of our daily examination of the patient, to get details about depth, as if we're seeing tissues from the side in big and large details. The other way we use instead of the direct illumination is the retro illumination. Retro illumination can be done by looking at the reflected light from opaque structure underneath. The structure we go through while examining the patient on the slit lamp is the iris into the anterior segment and the retina into the posterior segment. Here, the compound microscope and the light intensity, the light source has to be tilted to 45 degrees, and we see here in the back shadow. We don't look into the slit lamp, but we look into the reflection of the light back onto the adjacent structure, and this is how we do it. Here, for instance, while projecting the light, the back scatter of the light makes the ciliary body melanoma visible in details, and also the back scatter light. We look at the adjacent structure as it is reflected, as the light is reflected from the deeper opaque medium زي الايرس هنا, وده can show us subtle details like KPs on the cornea and minimal changes in the epithelium like microvasicles in the epithelium as well. A retroillumination is we see the in the back reflection of the light going onto the retina, whatever anterior segment structure we focus the objective on. والحقيقة هنا we can see the Krukenberg spindle beautifully represented. Here the light goes coaxial with the binocular, and we don't look at the light, we look at the reflection of the light from the pupillary margin. You can see the KPs forming the Krukenberg spindle in such a case. If you want to complicate matter more, we use a 4 millimeter tall slit beam, 1 to 2 millimeter wide with high brightness and 10x magnification. Here, the light has to be decentered from the light beam and it goes laterally. Here we use the property of the cornea as a total internal reflecting surface to look at how the light behaves onto the cornea and gets out from the other side of the limbus. Such an example, we go short. You can see the limbus here on the temporal is eliminated at certain angle when the light beam with high intensity falls on the nasal limbus. Look at the temporal limbus. The light goes total internal reflection and it gets out of the temporal limbus. If we have any structure that is inducing opacity of the cornea, no matter how subtle it is, you will see it as it will obscure some of the light going into the cornea. And this is the sclerotic scatter, and this is how we elicit it, and this is how we do it. It's very important to tilt the beam, and I will show next slide how to tilt the beam to be able to have the sclerotic scatter. One very important use الحقيقة, and we rarely resort to this if you want to really appreciate the endothelium and the endothelium mosaic. This is called the specular refraction. We use a small beam that is 1 to 2 millimeter tall by 1 millimeter wide, low to moderate bright with high magnification, and the angle here of the observation has to be equal to the angle of illumination to see the mosaic. And this is how we elicit the angulation. هنا the illumination angle has to equal the observation angle 30 degrees each. يعني the distance هنا between both is like 60 degrees. And we go on the short, thin cut with high illumination, and we focus on the cornea and we look at the endothelium, trying to get the mosaic of the endothelium just at the inner side of the rectangle, inducing the light reflection. It's very difficult to elicit الحقيقة, but دي حاجة that we have to keep in mind and to يعني look for it, and we can appreciate besides the KPs or so the polymagnetism sometimes of the end of the endothelium. The slit lamp comes with lenses عشان الcriteria of the total internal reflectivity of the cornea will not allow us to see the angle of the anterior chamber or the vitreous or the fundus, the rest of the fundus. So we have to eliminate the power of the cornea, and how to eliminate it, we have to put on it contact lenses or use the biomicroscopic lenses, plano-concave or the panfundoscopic lenses. البلينو-concave زمان في السيت لامب they used to have the ruby lens, which is not more present anymore. When we use the biconvex lenses in our everyday practice, that comes with different magnification, and they do give us a fair view of the fundus, whether wide angle or narrow angle or optic nerve evaluation, or so, depending on what we want to do. The auxiliary devices, the applanation tonometer is mounted on the slit lamp, and we use the fluorescein on this prism to see the mirrors of the split inner split mirrors to be touching on from inside to determine the intraocular pressure. And this is a very fair and accurate method of IP measurement. وبرضه we can mount a pachymetry on the slit lamp to give us depth of the anterior chamber and also the cornea. There is an interesting method to see to look at the depth of the anterior chamber. It is to bring the slit beam onto the lateral limbus or the nasal limbus يعني أو temporal limbus, and to evaluate the depth of the cornea regarding the depth of the anterior chamber. So if the corneal diameter on the slit beam is 3 times more than the anterior chamber depth, so we have a narrow or an occludable angle to be confirmed by the slit lamp gonioscopy. والحقيقة الجونيوسكوبي is a very useful tool, and I believe إن في محاضرة على الجونيوسكوبي. I just want to share with you a few pictures of مثلا why subscleral trabeculectomy doesn't work in congenital glaucoma, because the iris root just close off the trabeculectomy being so soft to D. صور gonioscopy by the red cam. دي صور trabecular dysgenesis where the posterior iris insertion into the Schwalbe's line, preventing the details of the trabecular meshwork. This is why gonioscopy work in those patients. This is a very nice description of the angle in a patient with aniridia. It processes the very short remnants of and the ciliary pars plana and the periphery of the lens and the periphery of the retina. Here is a very beautiful presentation of the Peters anomaly. You see the iris membrane going on back of the like a sailor boat presentation, which has a significance طبعا sitting into the anterior chamber, persistent pupillary membranes, pigment dispersion syndromes, and we have different types of slit lamps to end with the handheld slit lamp that is very useful in camping and in camps and in home visits if you want to plan with children. Of course, this is a very useful tool. The regular slit lamp, the Zeiss model slit lamp, and each has the same principle, but different way of applying the technique we're using to see the patient by different inventors, but they hold all the same principle. بس انا كده خلصت المحاضره الحقيقه، ولو في حد عايز اي اسئله او كده يتفضل.